She is proud daughter of our respected late Professor Abdul Hakim Sir, ENT from Assam Medical College. And she is my batchmate and she is very close friend of mine. Her detailed biodata will be given by Mukherjee Sir. And moderator of the session is respected Dr. S.N. Mukherjee Sir. Sir has done MS-ENT from prestigious institution AIMS, New Delhi. Sir has worked as MD, Railway Hospital, Maligaon for 32 years. And Sir is now senior faculty of DNB associated with Downtown Hospital. Sir is an avid reader and has excellent career as ENT consultant. Over to you, sir.
Okay. Good evening, everybody. Am I audible, sir? Am I audible, Anjana?
Audible, sir, but a bit louder will be better, sir.
Okay. Then I'll change the microphone, headphone.
Yes, sir.
Now you don't change. You start. Otherwise, again you take a problem.
Sir, মাজতে ভালে আছিলে এটুকে কক এতিয়া ঠিক আছে স্যার
এতিয়া ঠিক আছে
yes
ৰবা মই লগোৱা নাই এতিয়া hi can you hear me now
yes sir
okay now I think good evening everybody because this is a very important discussion on the recent advances in anaphylaxis. As you all know, anaphylaxis is a life-threatening allergic reaction. This can occur within seconds and minutes on exposure to the allergen. And again, Robert and Phil Gell in 1963 has divided the types of anaphylactic reaction in type 1, which is immediate within seconds and minutes, and type 2, which is cytotoxic. Then type 3 is immune complex mediated, and type 4 is the delayed hypersensitivity. It may take even hours, 48 to 72 hours. This is again cell mediated immunity. I think again we'll discuss on the drug induced hypersensitivity also, the types. I think first of all I must introduce Dr. Fozia Hakim. She is our active member. And she was treasurer of our NEBOI. She has done MBBS and MS from AMCH. She worked as fellow and research officer in AIMS, New Delhi for 5 years. Currently, she is consultant and ENT surgeon at Archana Hospital and Ajiz Hospital, Dibrugarh. Active member of the Rotary Club and then consultant in Prosuti Cancer Palliative Trust. He has done advanced allergy and immunotherapy course from Karnataka in association with Boidehi Medical College under Penduram Anand. And now I would request Fozia to start with her presentation. Fozia, please.
Thank you, sir. Good evening, everyone. Just let me share.
What is share screen, Fozia?
One minute, sir.
Ulana to aha nai.
Skin aha.
Anai ma.
Skin aha nai.
Nai aha.
নাই হা তোর ভিডিওটা অফ করছুন Fozia তোর ভিডিওটা অফ কর
অথনি শেয়ার হৈ আছিল তো মই শেয়ার কৰিছো নহয় মোৰ এটা ভুল হলো শেয়ার স্ক্রিন দিব লাগিব ন আইছে নে
আইছে মা
আইছে ডাঙৰ কৰি দিয়া
গুড
নেটৱৰ্ক আজি বৰ বেয়া ইমান বেয়া নেটৱৰ্ক নহয় মাজে মাজে ডিসকানেক্ট হৈ যাব নিচিনা লাগিছে
it's okay you go ahead
good evening everyone today we are going to discuss about anaphylaxis, a recent update. Anaphylaxis represents the worst severe end of the spectrum of allergic reaction. Different definitions for anaphylaxis are currently in use in the literature. World Allergy Organization, in short WAO, has come up with a modified definition: a serious, life-threatening, generalized or systemic hypersensitivity reaction and a serious allergic reaction that is rapid in onset and might cause death. It is given by World Allergy Organization. People get anxious very often when they talk about the condition, and this affects the health workers, that is doctors, nurses, as well as patients and family members who might suffer from the problem. This is a management problem. If managed seriously, the outcome is very good indeed. Anaphylaxis can occur by some day-to-day material like food, insect, sting, medication, etc. If it happens in hospital setup, and the hypocrisy, if we should not do any harm to the patient. If it happens, we should manage it properly as quickly as possible. So all doctors, nurses do need to manage anaphylaxis. Now, a little about the history of anaphylaxis, how the terminology has come. The term anaphylaxis was first given by Charles Richet and Paul Porter in the year 1902. They were basically immunologists, and they were doing research work on immunology. And they were doing trial with the Physalia and Actinia extract. It is a sea anemone, and they have experimented on dogs. And while doing experiment on the first exposure, there was no reaction, nothing was there. But after 22 days, they have given the second dose with high dose. And after some time, the dog started showing symptoms like vomiting, blood in stool, respiratory problem, stridor, and all the symptoms. And within 25 minutes, he collapsed, died. Then he gave the name reaction as a lack of protection. Later on, he was not satisfied with this name and given aphylaxis. A means negative and phylaxis is protection against the infection. Even if he was not satisfied because of euphonic and rhythmic reason, he preferred to give the name as anaphylaxis. And this term immediately spreaded all over the world as anaphylaxis. 15 February 1902, at Society of Biology in Paris, they have presented this phenomenon. And that is the turning point of this birth of modern allergology with the discovery of phenomenon of anaphylaxis. Richard received Nobel Prize in 1913. And this history of this phenomenon, he has given the name anaphylaxis, but this phenomenon was present from long before. A history says that 2641 BC, famous Pharaoh Menes, he died of by wasp sting infection.
Right.
And Ulrich Müller also described some this type of phenomenon in 1765. Also, there is history of same type of reaction. So, as there is no definite guideline for diagnosis of anaphylaxis worldwide, World Allergy Organization has given some guidance for the diagnosis. The objective of this guidance are to increase global awareness of current concepts in the assessment and management of anaphylaxis in healthcare settings globally, which is very important, and to prevent anaphylaxis recurrences in the community. This is also very high in rate. Reduce avoidable deaths and to improve allocation of resources for the anaphylaxis.
Right.
Now, these are the different definitions given by different society, allergic society, American Academic Allergy, Asthma, Immunology, American College, Asthma, Allergy and Immunology, Australian Society, World Allergy Organization, World Health Organization, different types of, but there is no such consensus general definition of allergy is there. They've got different allergies. In India also, we don't have any allergy definition. We followed the World Allergy Organization definition. So, what is the epidemiology?
Yeah.
Lifetime prevalence is 0.3 to 5.1%. In children, 1 to 761 per 100,000 persons per year. But the worrying data is recurrence rate, that is 26.5 to 54.5% recurrence rate is there in follow-up of 1.5 years to 25 years.
Yes.
And mortality remains low, it is not much, 0.05 to 0.51 per million people per year for drugs. And for food, it is 0.03 to 0.32 for food. And for venom, it is 0.09 to 0.13. Prevalence, lifetime prevalence 0.5 to 0.3%, between 30 to 950 cases per 100,000 persons per year. Risk of recurrence is 1 in 12 per year. This is also very high. Predisposition. Who is more prone to anaphylaxis? It is said that atopic people are more prone because they are the people with atopia. They are exposed to allergen in everyday day-to-day life, and they are producing IgE, antigen-specific IgE in the body, and this gives rise to in future the anaphylactic reaction. Same with asthma and allergic rhinitis. Food allergies also is same. And they said that 0 to 4 years, people, the children, they are more prone, and in older age, more above 60 years, they are more prone. And vitamin D deficiency shows more proneness to the allergy. And hygiene hypothesis, everybody as we know that people who have not exposed themselves to any allergenic challenges, they are more prone to this anaphylaxis. Children who are very clean, they stay in very clean places, they are not exposed to animals. These children, they are more prone to anaphylaxis. Now, in short, the pathophysiology. Basically, anaphylaxis is a type 1 hypersensitivity, and it has got two phases. Phase 1 is sensitization, phase 2 is effector phase. Sensitization, it is, we know sensitization phase. Here, there is a primary dose of sensitization dose, that is allergen, which come in contact with the person, human body, and contact with the antigen presenting cell. This dose is called sensitization dose. And it processes and presents two T helper cell too, and then unprocessed, they ultimately produces plasma cell. Plasma cell and memory cell. Plasma cells in turn, they produce immunoglobulins. Lot of immunoglobulins are liberated from the plasma cells, and they are in the circulation, they are in the tissues. And plasma cell has got two limbs. They have one FC, another one is FAB. So as soon as the plasma cell, this in the immunoglobulin are in the tissues, they start searching for the target cell. Here the target cell is basophil, and in tissues it is mast cell. These mast cells contain granules inside, and these granules contain inflammatory chemical mediators. This mast cell has on its surface some receptor called FCR. These receptors is the surface receptor. These are FCR receptors, where this FC segment of the antigen, this vertical segment, that is FC segment, that goes and attaches with the FC receptor site of the mast cell. And as soon as it is attached in the mast cell is sensitized. Sensitized. This immunoglobulin is antigen specific. That particular antigen who has come, maybe it may be whatever it is, that particular antigen, this immunospecific immunoglobulin is attached to the mast cell, and this time this mast cell is sensitized, waiting for the second exposure to that particular antigen. That particular antigen. So re-exposure to antigen, now this antigen is called as allergen, because after exposure to this allergen, there will be, as soon as this allergen is exposed to the body, it will come to the FAB limb of the IgE, the other limb, this one.
Mm.
Here it will come and attach with the FAB, that is antibody antigen complex will be formed here.
Yes.
So as soon as the antigen antibody is formed, there is destruction of the membrane of the mast cell and degranulation.
Membrane.
So this is degranulation, this is the activation of the mast cell, and this degranulation occurs. These granules contain some chemical mediator, and this chemical mediator later on they will produce the effector phase. Now I will just tell some steps. Effector phase I will tell just later on. I will go the types of anaphylaxis, like in between. What are the different types of anaphylaxis? Immunologic mechanism, that is IgE mediated. Another one is IgE independent. Third is non-immunologic mechanism. This is mast cell activation is there, and idiopathic anaphylaxis. So here, despite expressing the effect is same, common clinical features, all the this classification is given, but effect is same complaint will be there, but a mechanism will be different. Nevertheless, some of the activated pathway may be common in different types of anaphylaxis reaction or be present simultaneously. Two pathways may be present simultaneously. So IgE mediated immunologic mechanism, food, medication, seminal fluid, venom, radio contrast media, occupational allergens, aeroallergen, natural rubber, latex, etc. are come with this IgE mediated. And this is considered to be as classic and most frequent mechanism which is encountered. And non-IgE independent, that is IgE independent, that is radio contrast media, NSAID, dextran, biological agents. These are non-IgE mediated anaphylaxis, may be immunologic or non-immunologic also. The most relevant non-IgE mediated immunologic mechanism may involve the activation of pathways such as complement system, coagulation system activation, or immunoglobulin G mediated anaphylaxis.
IgG and IgM.
This is a picture where you can see this is immunologic activation, which I have just explained, this one. And this is non-IgE pathway, where different antigens come with different pathways. And they cause same symptom. They will release all these mediators, same mediators will be released. So non-immunologic mechanism have been described as some drugs, opioids, ethanol, physical factors. That is important, such as exercise, may be involved in triggering the anaphylaxis. But exact mechanism in detail is not till now it is not elaborated. Mast cell may be activated through receptors such as mast-related G protein couple receptor by certain drugs such as neuromuscular agents and fluoroquinolones. Anaphylaxis is classified as idiopathic. Another one is idiopathic, when no trigger can be identified and currently represents between, this is very important, 6.5 and 35% cases idiopathic variety is found. That is, there is no allergen is found, depending on the studies. In this type of cases, mast cell disorders should be ruled out. Now, let us go to the effector phase. Effector phase, that when the degranulation occurs, chemical mediators from the mast cell, they are released. There are two types of chemical mediators. Primary chemical mediators, they are histamine and serotonin. These histamine and serotonin are present inside the mast cell in already preform state, and they are ready to affect the body. So they don't have to synthesize after coming out from the mast cell. So they are immediately they will come into action. And secondary chemical mediators, these are activated once there is exposure to the shocking dose, and they are synthesized, and then they will come into action. They are leukotriene, prostaglandin, cytokines, platelet activating factors. So what will be the effects? Primary chemical mediators, histamine and serotonin, they will cause increased smooth muscle contraction, increased vasodilatation, increased vascular permeability. And secondary chemical mediator, they will increase vascular permeability and increase pulmonary smooth muscle contraction. Together, they give rise to the local and systemic effect of this anaphylaxis. So they may lead breathlessness, hypotension, shock, sometimes even death. So what are the elicitors and cofactors influencing anaphylaxis? Age-related factors, concomitant diseases, associated any disease, yes, concomitant medications, what is taking, cofactors that amplify anaphylaxis. Triggers, mostly food. Food is the most common elicitor group worldwide are food, insect venom, and drugs. So food-induced anaphylaxis in children is most common, like hen, cow's milk, wheat, peanuts, etc. In school-going children, it is very much common. In adult, food-induced anaphylaxis varies depending upon the region and local food exposure. In different regions, different types of foods are available. So in according to places, the anaphylaxis to substance are different. Like in North America and Australia, peanut, tree nut, these are very common. In Asia, shellfish is very common. Like that Middle East, it is sesame seed. Recently, it is found that sesame seed is very anaphylactic. Even death has occurred after taking sesame seed. Mite ingestion. In some places, people ingest mite. So oral mite anaphylaxis can be seen after ingestion of the mites. Venom induced shows regional pattern. Bee sting venom is found in Korea, South Korea, Central Europe, West, America, Asia, red ant, and part of Australia also. Antivenom. In snake bite, we give antivenom. This antivenom can also show some anaphylactic reaction sometimes. Now, drug-induced. Aspirin, NSAID, parental penicillin, plasma, streptokinase, dextran, contrast media, blood, these things, they can produce anaphylactic reactions. Biological containing alpha-gal, that is the recent one with chemotherapeutic medicines, they cause anaphylaxis. And disinfectant like chlorhexidine, polyethyl glycol, methyl cellulose. So it is very important before administration of any medication, history is very important. As the patient, ask the patient about any type of allergy, always check name, age, allergy history of the patient, birth date. It is very important. Every time we see a patient, we should ask all these: name, age, allergy history, and birth date. And proper dose, proper route should be administered medicine. Now, about the cofactors. And another elicitor group are rubber, latex, seminal fluid, and medical dye, substances which are administered during perioperative settings, like suxamethonium, requirium, thiopentol, propofol, opioids, protamine, chlorhexidine, and plasma expander also, they cause anaphylaxis. So the outcome and severity of anaphylaxis does not only depend upon the elicitors and its dose, but also presence of cofactor. Cofactor also has some role in producing anaphylaxis. So cofactors are divided endogenous and exogenous. Systemic mastocytosis, unstable bronchial asthma, the hormonal status of the individual, like in premenstrual condition, the hormonal status is different. So these conditions also play some role. Exogenous, physical exercise, infection, alcohol intake, psychological burden, sleep deprivation, medications. People who are taking beta blocker, S inhibitors, they are more prone to anaphylaxis. These factors are age dependent, and its effect is also varied. In different persons, it is variable in. Now, what are the common clinical features? Clinical features divided in cutaneous, respiratory, cardiovascular, and gastrointestinal. Neurological, basically there is no direct neurological complaint, but it is secondary to the above symptoms. So cutaneous features, 80 to 90% of cases in adult have cutaneous symptoms. Now, why 80 to 90%? Usually cardio and respiratory symptoms are associated with cutaneous features, but sometimes these cutaneous symptoms may not be present. Anaphylactic patient may come with only cardiac symptom or cardiac and respiratory symptom. Skin symptom may not be there. So it is very important for diagnostic purpose, as because skin symptom is not there, we cannot rule out anaphylaxis. So there will be skin symptom will be flushing, itching, urticaria, erythema, swelling, and angioedema. Flushing is because of a feeling of heat due to vasodilatation. Because of the effect of histamine, there will be vasodilatation and it will cause flushing. Itching or pruritus due to mediators. And urticaria due to extravasation of capillary fluid. There will be capillary dilatation, and capillary permeability is also increased for the second, so there will be extravasation of fluid and it will cause urticaria, erythema, redness caused by peripheral vasodilatation. Sometimes whole body, previously it was said that it is a red man syndrome. Swelling of an angioedema both occurs due to the extra vasculation of fluid in skin and mucosal lining. Extravasation of fluid in skin and mucosal lining, like in lip, mouth, pharynx, back of the mouth, lungs, causing potential airway obstruction. Now, respiratory features. Respiratory features, again, it is like upper airway and lower airway. Upper airway, running nose, congestion, sneezing due to angioedema. There will be swelling and these things will occur. Throat tightening, feeling of closing up. This is swelling can be massively reduce the space, causing this problem, because there will be swelling and they will feel throat tightness and feeling of closing up, hoarseness because of the swelling of vocal cords, and wheeze will be because of the lower respiratory effect. Dyspnea may be there because of bronchoconstriction. Lower respiratory, basically because of bronchoconstriction, there will be dyspnea, and tachypnea because of compensatory cope up with the dyspnea, there will be compensatory tachypnea. Hypoxia due to decreased bronchoconstriction, there will be oxygen will be less, and there will be confusion state, oxygen low, hypoxia, brain hypoxia will be there, and patient will be in the hypoxic and confused state, and ultimately there may be respiratory arrest. Now, cardiovascular symptom. Due to histamine effect, there is vasodilatation causing reduced peripheral resistance, leading to low blood pressure, a state of acute hypotension, which causes reduced tissue perfusion and leading to shock. Patient will be pale and clammy. Hypotension will be there, and to compensate hypotension, heart will pump more and there will be tachycardia. Reduced level of consciousness due to reduced cerebral perfusion. There is decreased oxygen and cerebral hypoxia lead to low level of consciousness. Chest pain due to low BP leading to reduced perfusion of the cardiac arteries, causing myocardial hypoperfusion and coronary artery hypotension, causing symptoms like angina, even if the patient is not having any coronary artery pathology. And this leads to cardiac arrest. Gastrointestinal feature, it is, we all know that all whole gastrointestinal tract is lined by mucosa. So whatever effect is in mucosa, all will be there in the gastrointestinal tract, and there will be nausea, vomiting, abdominal pain, and incontinence of stool. Neurological features, they are basically secondary to respiratory and cardiac symptoms. Patient will be panic and restless and anxious due to respiratory and cardiac problem. At this point, counseling is very important. Patient is counsel properly. Headache and dizziness due to cerebral hypoperfusion leading to hypoxia. Blurring of vision, it may be due to lack of blood supply in the visual cortex. Metallic taste due to effect of chemical mediators, and feeling of impending doom. Because of these symptoms or the other symptoms, patient will feel that I am going to die, and they will be more anxious, more panic, and reassurance at this point is very important. Whenever the patient comes, and first of all, the reassurance that you will be okay, don't worry, everything will be within minutes, you will be okay. So Now, the diagnostic criteria of anaphylaxis. Anaphylaxis is highly likely. Diagnostic criteria, actually, World Allergy Association, they have given one diagnostic criteria, this one. It is given in 2011, but they have modified it in 2020 with these guidelines. Anaphylaxis is highly likely when any one of the following two criteria are fulfilled. Criteria number one, it is acute onset of an illness, minutes to several hours, simultaneous involvement of skin, mucosal tissue, or both, generalized hives, pruritus and flushing, swollen lip, tongue, uvula, etc. And at least one of the following, along with these skin symptoms, there one of the following three symptoms like respiratory compromise, reduced blood pressure, or associated symptom of end organ dysfunction, that is hypotonia, collapse, etc. Severe gastrointestinal symptoms, skin symptom, and other, this one of the other three symptoms should be there to diagnose as a anaphylaxis. And second group says acute onset of hypotension or bronchospasm or laryngeal involvement after exposure is known, or highly probable allergens minutes to hours even in the absence of typical skin involvement. Skin involvement may not be there, but these hypotension, bronchospasm or laryngeal involvement may be there. In infant and children, low systolic BP or greater than 30% decrease in systolic BP from the baseline is supposed to be hypotension. In in children below 10 years, systolic BP less than 70 millimeter plus 2 into age in years, and adult less than 90 millimeter mercury, it is said to be hypotension. Laryngeal symptoms, they are these vocal symptoms and odynophagia. Some grading, World Allergy Association has given some grading for allergy anaphylaxis. Grade 1 to 5 they have graded. 1 and 2 they have not taken as anaphylaxis. 3 to 5 is anaphylaxis. Grade 1, they are containing symptoms and signs of cutaneous symptoms, urticaria, erythema, warmth, all skin symptoms are there. And nasal symptoms will also be there, upper respiratory symptoms, that means, and throat clearing and conjunctival symptoms will be there. In grade 2, symptoms of this and another organ, also 2 organ is present. In grade 3, bronchospasm will be there, cough, wheeze, but it will be improved after medication. So this is grade 3. In abdominal cramp also and diarrhea. Grade 4, bronchospasm and all respiratory symptom will be there, and it will be worsening in spite of giving treatment. This is grade 4. And symptoms of grade 1 and 3, 1 and 3 symptoms will be included here. Grade 5 is the ultimate, that is respiratory failure, cardiac collapse, hypotension, everything will be there in grade 5. Now the diagnostic test. During acute attack of anaphylaxis, serum tryptase level are increased from 15 minutes to 3 hours or even longer. After the onset, in 1 to 2 hours, in some study, they have seen 36 to 40% remaining less than 11.4 microgram per liter tryptase. This is normal level. But even if it is normal, we cannot say that it is not anaphylaxis. Positive tryptase level confirms the anaphylaxis, but negative tryptase level does not exclude anaphylaxis. This is important. And management in recurrent another 24 hours after resolution, after 24 hours, this anaphylaxis tryptase should be measured just to prevent refractory anaphylaxis, recurrence of anaphylaxis. To avoid it, we have to do the tryptase testing. Acute treatment of anaphylaxis. Anaphylaxis is a medical emergency that requires rapid identification and treatment. Here, patient with anaphylaxis, that is diagnosed case of anaphylaxis, patient already had a attack of anaphylaxis, they can be managed in 2 stages. Self-management by the patient using an emergency protocol, in which it is important to emphasize the key role of intramuscular epinephrine. And secondly, additional intervention given by healthcare professional once medical help arrives, which must include further epinephrine if symptoms of anaphylaxis are ongoing. They will repeat the injection. Now, steps to follow while giving treatment or diagnosing a case of anaphylaxis. There should be a written emergency protocol for recognition. Removal of exposure is first line of treatment. If there is a wasp sting, it should be removed very carefully. If patient is given blood or any IV fluid or any type of chemotherapeutic medicines, immediately once it is diagnosed that it is anaphylactic, some reactions are there, immediately stop the medication or stop the triggers. Assess the patient A, B, C, D, E, all levels, call for help, inject epinephrine immediately. Simultaneously, these 3, 4, 5 should be done simultaneously immediately. Patient should be placed on his back or in a comfortable position. In asthmatic patient, they can position in a sitting position, and in pregnant women they can sleep on left lateral position. High flow supplemental oxygen when indicated, not always. If we see that oxygen level is low, then there we can give high flow supplemental oxygen, and establish intravenous access by a wide bore needle. Wide bore needle is to be given for the root. If indicated, at any time perform cardiopulmonary resuscitation. If we see that patient is going for cardiac arrest or respiratory arrest, we can go for cardiopulmonary resuscitation at that point. At frequent irregular intervals, monitoring patient blood pressure, cardiac rate and function, respiratory status and oxygenation is continuously has to be monitored. Now, epinephrine. Epinephrine or adrenaline. The World Health Organization classifies epinephrine or adrenaline as an essential medication for the treatment of anaphylaxis. Epinephrine is a life-saving because of alpha-1 adrenergic vasoconstrictor effect in most body organ system and its ability to prevent and relieve airway obstruction causing by mucosal edema, bronchoconstriction, and to prevent and relieve hypotension and shock. So it comes in three forms: auto-inject, needle kit, a pre-filled syringe, and in vial. Rapidly disintegrating epinephrine sublingual tablets are on the way. It is yet to be approved. Before giving epinephrine, some points to be remembered, that whether the patient is having any allergy to this medication. Pediatric group, geriatric group, and breastfeeding mothers has to be assessed properly. Any drug interaction, whether any drug they are taking, like if there is patient is asthmatic or cardiac disease or hypertension is there, or angina pectoris, any cardiac problem patient is having. So in those cases, we have to very carefully administer the dose. Proper use, that is proper dose, proper duration, and by health professionals to be given. Now, what is the dose? It is to be given only by intramuscular route in emergency cases. 0.01 milligram per kg body weight to a total dose 0.5 milligram per kg body weight, 1 in 1000 solution, that is 1 milligram per ml. Depending upon the severity of the episode and response to the initial injection, dose can be repeated every 5 to 15 minutes as needed. More than 2 injections occasionally is required. In contrast, intravenous route, there is cardiac arrhythmias with bolus dose. So, intravenous route of administration is recommended only in good setup and by an expert who has knowledge of diluting epinephrine. In upper airway obstruction, nebulized adrenaline can be used. These are the doses for different age groups. Now, apart from adrenaline, what are the second line of treatment? Second line of treatment in addition to adrenaline is H1 antihistaminics, chlorpheniramine, diphenhydramine, and clemastine by IV route. And again, it should not be given very rapidly, because if we give rapid these things, they will cause hypotension. Beta 2 adenosine agonist with lower airway obstruction, that is bronchoconstriction, salbutamol, albutamol can be given, but not much helpful. Upper airway obstruction, epinephrine nebulizer we can use. Glucocorticoids to prevent protracted symptoms, and if patient is having asthmatic symptom, in those cases we can give glucocorticoids, and to prevent biphasic anaphylaxis we can go for glucocorticoid. H2 antihistaminics, this also has got not much role. They will relieve only the skin complications. IV glucagon when no response with adrenaline and patient is taking beta blocker to prevent protracted symptoms, go for IV glucagon. Now, in refractory anaphylaxis, when there is no response by treatment, refer the patient to a higher center promptly with IM epinephrine injection, positioning of the patient, supplemental oxygen, IV fluid resuscitation, and second line medications along with the patient in the ambulance should be there, if possible, to a center where specialist team with emergency medicine, critical care medicine, and anesthesiologists are available. Now, once the patient is treated in the acute treatment is given, acute attack, we have given the treatment. For long-term management, what should be done? Aim is to prevent recurrence. 26.5 to 54.0% recurrence is there in 1.5 years to 25 years study. So it is very important, we have to prevent recurrences. At the time of discharge, train them how to inject epinephrine, and self-administration is very important. Should have written personalized anaphylaxis emergency plan and medical identification methods. They should be given a personal anaphylaxis emergency plan, how to tackle the immediate emergency part. They should do themselves till the health officials they come. In absence of epinephrine auto-inject, alternative formulations such as pre-filled epinephrine syringe. It is there in some places, pre-filled epinephrine syringe, or in absence of it also 1 ml syringe needle and epinephrine ampoule with adequate training and written instruction for drawing up the correct dose is to be taught. Epinephrine auto-inject available in 0.1 milligram, 0.3 milligram, and 0.5 milligram. Guideline recommend that patient with anaphylaxis be referred to allergy and immunology specialist for further management, which includes confirmation of suspected triggers, advice to prevent, and where indicated, consider for allergen immunotherapy. Annual follow-up for review of prevention of recurrence, and epinephrine auto-inject use, and optimize control of comorbidities like asthma. Idiopathic variety to assess carefully to rule out mastocytosis. Avoidance of allergen and trigger. However, for children, it is so many times it is very frustrating to follow avoidance, because if we say them, you don't take this food, you don't go to this. So it is very difficult to make them understand and make them follow the instructions, and they hamper the quality of life. So follow up with an dietitian and psychologist is very important at this point. It is very important. Parallelly, along with this, they should consult a dietitian. If one food they cannot take, then alternatively what they can do, and psychologist for psychological counseling. Now, global availability of epinephrine auto-inject. This is epinephrine is recommended as an essential medication for the treatment of anaphylaxis by WHO. Despite the epinephrine autoinject is not available in majority of the countries. It is limited to only 32 countries out of 195 world countries, mostly in high income countries. It is available. And for procuring, it needs a special license arrangement. And for in the name of a patient, they can bring it, and in suitcase trade, they bring it, but it is in the black marketing. Very costly. It is 2,500 to 3,500 one injection. But whoever will require one injection, they will require it in subsequent time also. So what is the unmet need? Anaphylaxis is poorly recognized, causing delay in appropriate treatment. Severity scoring system, no consensus till now. Guideline harmonization is required. Till now, there is no guideline as such, universal guideline. Epidemiological study all over is required. Regional variation, prevalence or in the incidence for frequency of anaphylaxis, etiology and risk factor, cofactor are poorly characterized, may be influenced by regional and national differences in allergen exposure and genetics. Large population-based study can support the understanding of the natural history of anaphylaxis. A standardized diagnostic procedure, serum plasma tryptase measurement are recommended in the diagnostic evaluation. Diagnosis of allergy sensitization is made using skin test, serum allergen specific IgE, and provocation test. Other complementary tests like basophil activation test and complement test. Better understanding of the pathophysiology of anaphylaxis, better availability of epinephrine autoinject. Only 32% of the world countries have it, absent mainly in low and middle income countries. No consensus for how long a patient with anaphylaxis is to be observed in healthcare settings. Anaphylaxis diagnosis and management should be included in undergraduate training so that they know when to refer to allergy specialists. Because in emergency setup, these doctors only face the anaphylactic patients. National policies for the availability of epinephrine autoinject in public settings, school, public transport, and parks, etc. Anaphylaxis research to be encouraged in private as well as in national programs. Need for establishing multinational large database registries for the implementation of the strategies and healthcare policies. Because without a big database or registries, they cannot implement the guidelines. So it is very important for study is very important to bring a guideline. So thank you for patient listening.
Good. I think thank you, Fauzia.
Thank you, sir.
It is really I'm happy to see such a elaborate discussion on anaphylaxis in such a short time. It is not possible to cover all the aspects of it.
Yes, sir. Still so many things are there. Yes, yes, sir. Yes, sir.
Right from the drug-induced anaphylaxis, hypersensitivity,
yes, sir.
and then Stevens-Johnson syndrome,
yes,
and then a lot of other things are there. I would like to mention few of the things which I think it will rather increase the whole presentation. Firstly, drug-induced hypersensitivity. It is IgE reaction type 1. It can happen anaphylaxis to beta-lactamase antibiotic.
Yes, sir.
Then type 2 is cytotoxic. It can be hemolytic anemia from penicillin.
Yes,
In
sir.
type 3, it is immune complex. It is serum sickness or acute thrombocytic globulin. Then type 4 is the delayed type of cell-mediated, that is contact dermatitis, or
yes, sir.
This locally topical antihistaminics. It also can cause contact dermatitis. Then specific T cell activation, like morbiform ash for seafoods, etc. And FAS and FAS ligand induced apoptosis, that is Stevens-Johnson syndrome.
Yes, sir.
Now, another important thing is that this
gel cum, I have told already in 1963.
Yes, yes,
Classified the
yes.
anaphylaxis. Now, type 1, it is IG mediated. It only takes about 2 minutes to have the effect.
Yes,
And
yes.
mostly because of this, maybe urticaria, angioedema, bronchospasm. But it is generally drug exposure as well as some food that can cause IG mediated reaction, plus bee sting, etc. Bite. Type 2 cytotoxic, that is specific IgM and IgD. That is antibiotics. That's all causes a drug implicated. Ultimately, it causes the complementary effect. Immunological, and ultimately it causes hemolytic anemia. Of course, this type 2 you can see in Bush-Pasteur syndrome, as well as myasthenia gravis, and also in cases of, I think, Graves' disease, where also this is the type 2 cytotoxic reaction. Then type 3, it is a sort of immune complex. The tissue dependent on the drug antibody complex and its complement. That happens in serum sickness as well as in Arthur's phenomenon reaction. That can happen this type 3. And then type 4 is again a delayed type of considered major histopathology complex, and it ultimately affects on the T cells. So there may be type 4 hypersensitivity can be again A, B, C, D, 4 types. Again, this can take even 24 to 72 hours after the exposure only. This develops. It may be in the form of contact dermatitis, or it may be tuberculosis. In fungal diseases, as you all know, fungal hyphae can cause also allergic reaction. So ultimately, it is again understood. But somehow I am happy you have covered the subject so nicely, because it is not possible to cover in such a small short period.
Yes, sir. These are all hypersensitivity reactions, sir. Yeah. And this anaphylaxis come in type 1 hypersensitivity.
No, but there are other types also. No?
Other types are also there. Yes, sir.
Yeah. I think it is the subject is open. Sir. Anybody wants to ask anything?
I think Purbu Ahmed sir is asking epinephrine. It is not available here, sir. But some places epinephrine auto-inject, it is not available here. But by that border, some people they bring and some people bring it from outside. But when you bring it from outside, it is very costly. And in Bombay, some people bring in the name of particular patient, because patient whoever is anaphylactic to some particular agent, they bring that from outside. Not here in India, it is not there. But we can go for that one. The third variety of epinephrine we can make use with our body weight measurement. We can keep, because it can be stored in room temperature. It should not be kept in. We can keep it in our bag also. According to the body weight, we make the solution, keep in the syringe and keep it in the bag whenever required. And another thing I have not told, that injection has to be given in the vastus lateralis of the
lateral aspect of the thigh.
Lateral aspect of the thigh, vastus lateralis of quadriceps. And immediately it has to be put. And there are some criteria like needles should not be too long for the children. It can, if it touches the bone, then that may cause necrosis and of the bone. And for adult, if it should not be very short also. Basically, the needle should go into the muscle only.
Muscle only, very good. Yes. There are receptors in the muscle which will respond.
Muscles, there are receptors in the muscle. Otherwise, in other places, it may cause necrosis by doing vasoconstriction.
Very correct. And another important thing is the danger of giving epinephrine. There are again some dangers associated with
it. In IV route, it is danger. That is why intravenous, it is recommended to be given in a setup where there is all
facilities for the cardio.
Yes, all facilities and cardio and anesthesia, critical care medicine people are there.
Very good, very good.
With a proper dose.
Gautam Khan sir and Pukan sir has raised the hand.
Please,
Can I come in?
Please,
sir,
please.
Yes,
Can I come in?
Please, sir.
Yes, sir.
Yeah. The first question for Dr. Fauzia is, you when you put the first title slide, You have spelled anaphylaxis as ANAPHYLEXIS. So it is anaphylaxis.
My mistake. This is my mistake.
Okay, that is the first question. And the second question is that one of my colleagues, junior colleagues, who departed recently, Mitam Borwa, when he went to UK, the first question when he wrote that some penicillin injection after skin prick test, he was reprimanded by his senior that why are you asking for a skin prick test? Because in UK, skin prick test is not recommended, because if you are going to have an anaphylactic reaction, you can have the anaphylactic reaction with a skin prick test, even without the injection proper. So with that sort of what is your comment? Because we have to change that mindset. Skin, we always write some injection after skin prick test. Because that mindset has to change. Because skin prick test actually is no guarantee that the patient is not going to get anaphylaxis. Rather we should have an anaphylaxis tray in all our sisters' cabins, or even in the OPD. If you are going to give
it should
injections
be
in the OPD.
not only in hospital setup, in our small clinic also we should be always prepared with anaphylactic management. In everywhere, in school also there should be that is why this subject is so what to say, underrated. Yes, underrated,
Yes.
and management is also underrated.
Yes.
And it has to be awareness should be there for anaphylaxis, because so many people we actually diagnose in casualty, like patient fainted for what, cardiac reason, respiratory reason, most commonly maybe it is an anaphylaxis. You
Yes.
never know, because it is not diagnosed or not examined properly. In normal faint, normal like syncope, in syncope
Vasovagal
what
attack.
happens? Vasovagal attack, what happens? There is pressure is low,
Yes.
and heart rate will be also, but in anaphylaxis pressure is low, along with that tachycardia will be there.
Yeah.
But in syncope tachycardia will not be there.
Right.
So there is some criteria where we have to differentiate, like with the general how to proceed, how to differentiate with normal symptoms.
Yes.
So that is very important. In casualty, it has to be there for the
Because
differentiation, whether
acute
it is
asthmatic attack also
anaphylaxis.
can present as a respiratory distress. Acute asthmatic attack.
Respiratory,
The
yes,
patient may have full
yes,
calamity extremity also.
Yeah, I
but
think we will
that
go.
actually
Can I
panic
take
attack,
part?
there is panic attack. In panic attack, there is
Yes.
BP will be high and tachycardia will be there. There will be no bronchospasm, and
Yes.
oxygen status will be normal. But in anaphylaxis, it is opposite. In children, there is breath holding. Some children, they hold the breath, and it
Yes.
may be patient may come with, the child may come with like why he has come, what has happened, what is the cause. So it has to be identified. So this is very important. Like faint, usually patients are bradycardic. Airway compromise is not there in those patients.
Okay, Fozia, I think we'll go ahead to Fukan sir.
Fukan sir, please.
Actually, Fozia, only differential diagnosis, as you have rightly said, is the vasovagal attack.
Yes.
And as Gautam is mentioned, I have also observed your history part, the same spelling E, but you have continued the spelling up to the last.
Sorry, it was a mistake, sir. Yes, it is
I thought that you are correct.
No, it is wrong. I have corrected somewhere, in some places it is wrong. মই correct কৰিলো যদিও ক'বাত থাকি গ'ল ইটো।
Sir, মই কি কওঁ, actually এই ৰমজান মাহটোত sir ফৌজিয়াক দিব নালাগিছিল। She was sleepy actually, sir. I take the blame, sir.
No problem.
But she has presented very nicely.
She was sleepy, sir.
No,
সেইটো
actually,
নহয় মই টাইপ ৰাতি টাইপ কৰিছো ন কি টাইপ কৰিলো তাৰপিছত মই দেখিলো এইটোতো হৈ আছে কিছুমান কৰিলো কিছুমান থাকি গ'ল মই চেক কৰাই
no,
নহ'ল
no, okay, okay. There you go. You leave that one. That is not
sorry sir
important.
for that
And another thing is that you see this, your allergy and anaphylaxis go side by side, but according to severity. But also the discovery of allergy by Clement van Parkwet, the Austrian pediatrician, also
Yes.
she also got the peculiar reaction of horse serum, anaphylactic reaction.
yes he has come with horse
coined
serum
the term allergy from the reaction.
Yes.
Another,
Yes.
in relation to Gautam's mythom, actually one sister was there in Silsar Medical College. She
Yes.
died of
Penicillin.
penicillin. I think
Yes, I remember.
you remember,
it
no?
is very common
Yes, yes.
sir in so
No,
many
not very
places it
common.
is very-
Not very
Yeah.
common. We are nowadays we are not using penicillin, benzyl penicillin. The
Yes.
long acting, this is short acting is benzyl, and long acting is the benzathine penicillin.
Benzathine.
And both penicillin are when skin test, it is in skin test she died, and
Yes.
she had got history.
No,
that when
interesting,
she-
Pukon. That
Huh?
case was diluted. The penicillin
diluted,
solution was
yes.
diluted. In spite of that, she reacted.
And moreover, when she touches,
she might be
when-
highly sensitive
no, when she touches the penicillin at that time in our days, penicillin was randomly given in an indoor patient.
Yes, very
And,
correct.
and when she touches, go near the penicillin vial, her skin also erupted out. And you have rightly mentioned from step 1 to step 5, but
Yes.
actually main problem with the respiratory and the cardiovascular part. You have rightly mentioned that one. There is
Yes,
a
yes.
step 4 and 5. That is the most
Yes.
important. And I have nothing to say. You have nicely have commented that.
Yes, she has
elaborately.
presented very nicely.
sir yeah one incident
So
is
one thing,
there
another question. One, you are in pathophysiology. I have
Yes,
a
sir.
memory cell. What is memory cell actually?
Yes.
memory cell that antigen specific jitu ahile heitue
Oh, the
Anjana,
cell,
please.
some cells are that then memorize the antigen.
Yes,
yes
yes,
from
yes,
the
yes.
antigen.
Yes,
yes
very correct.
Okay. In the second
that
attack,
particular antigen they keep
they will send it to the mast cell and your
Yes.
basophil. To
Yes.
no
make
the
it
second attack actually it is with IgE not memory
IgE.
cell memory cell does not come in
Memory
picture.
cell only remembers.
It
the-
stays
yes,
it remembers and it
Yeah.
stays
No, it's
somewhere.
IgE directs. I'm not telling about IgE. IgE is a different issue. IgE
Hmm.
directs the IgE to there, I think, to the mast cell.
No, sir.
Then what the
Memory
function
cell,
of memory?
memory cell and IgE both are produced simultaneously.
Yes.
Okay, but what
They
is
are
the
produced
function?
simultaneously from the B cell. Some becomes
Basophils.
memory cell and some
Yes.
becomes memory cell.
No, okay, what is
Memory
the
cell are
function?
nothing but they are basophil. I think no, Mukherjee sir. They are
Yes, yes,
basophils
yes.
only. They are
Yes.